Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today in our Conversation with Cancer Expert series, we have Dr. Dahlia Sano, who is Assistant Professor at the Rogel Cancer Center at the University of Michigan. And she's going to talk to us about some recent developments in chronic lymphocytic leukemia. We're honored to have her. Welcome, Dahlia.
Thank you so much, and thank you so much for the invite. I appreciate that.
Thank you for joining us. So we're going to talk about some select recent developments in this area. But before we do so, could you just give you a just broad overview of what is the armamentarium of drugs that we have for our treatment of CLL, and then we'll try to narrow it down to the specific abstracts that we have chosen for discussion.
Sure. So as we all know, the targeted therapy is now the way to go for CLL. BTK inhibitor, the first generation ibrutinib, and now we also have acalabrutinib, zanubrutinib, and pirtobrutinib approved as well. BCL2 inhibitor, venetoclax, is another important agent that also used as single agent or in combination. CAR T cell is one of the newer agent that recently approved for CLL. Monoclonal antibody typically used in combination with the targeted therapies. We have rituximab and obinutuzumab. Also, the chemotherapy drugs that uses fludarabine, cyclophosphamide, and bendamustine that we kind of not using as much currently as the more targeted agent.
So obviously, I guess the recent emphasis has been on BTK inhibitors and BCL2 inhibitors, and we've been using these drugs for a while. And lately, I guess we've started having some comparative data emerge on these. So what can you tell us about this trial with zanubrutinib and ibrutinib?
Sure. The Alpine trial looked at comparing zanubrutinib versus ibrutinib. Ibrutinib, as we know, is the first generation BTK inhibitor. Mainly looking at in the relapsed refractory CLL patient. The Alpine trial was a randomized phase 3 trial of zanubrutinib versus ibrutinib in patient with CLL relapse or refractory for more than one line of treatment and no prior BTK inhibitor. The trial showed that zanubrutinib was superior to ibrutinib with 78.4% progression-free survival compared to 65.9% with ibrutinib. The risk of atrial fibrillation or flutter, that one of the concern side effects with BTK inhibitor, was less in zanubrutinib arm, 5.2% compared to the 13.3% with the ibrutinib arm. Hypertension is another one concerning side effect, was comparable between the two. However, in the recent ASCO abstract presented, show that the need for antihypertensive were less with zanubrutinib compared to the ibrutinib.
And I guess there was another trial that looked at the other BTK inhibitor, acalabrutinib, and compared it to ibrutinib. And what were the findings from this study?
Correct. The ELEVATE-RR compared acalabrutinib versus ibrutinib in a previously treated CLL patient, and this was a randomized phase 3 trial. And they looked at patient previously treated with CLL with deletion 17 or deletion 11q, which, as we know, is a high-risk population. The trial met the non-inferiority trial with a hazard ratio of 1.0. The risk of atrial fibrillation was less with acalabrutinib, also at 6% versus 15% with the ibrutinib. Risk of hypertension was also less with acalabrutinib for grade 3 and more, 4% and 9% with ibrutinib.
So now more recently, we've had data on frontline use of zanubrutinib. We've been using ibrutinib and acalabrutinib in frontline for a while, but zanubrutinib is a recent entrant, relatively recent entrant in the frontline treatment. So can you tell us a little bit about this study that led to its frontline approval?
Yeah, the Sequoia trial looked at the frontline zanubrutinib, comparing it to bendamustine and Rituxan. That led to the approval of zanubrutinib like early last year. It was an open-label, part randomized phase 3 trial of zanubrutinib for patients who were untreated CLL, SLL requiring treatment. Patients were 65 and above, or more than 18 with some comorbidities. They were not suitable for FCR treatment, and the randomization was between BR. There was two cohort for 17p, and cohort 2 was the first cohort was without deletion 17, and the cohort 2 was patient with deletion 17p, as we know is a higher risk group. And the PFS was superior with zanubrutinib, 82.4% compared to zanubrutinib at 50%. Compared to BR at 50%. The progression-free survival in the cohort 2, which is the high-risk group, was very significant, actually 79.4%, which is very significant for this very high-risk group.
And what do we know about the safety profile of these two options?
Yeah, as we know, the zanubrutinib is very safe, and risk of hypertension was much less than the first-generation BTK inhibitor. Side effect of interest is the hypertension was seen, grade 3 and 4 was only 6%. Bleeding risk was also grade 1 and 2, 41%, which typically some bruises, very manageable. Grade 3 and 4 event were at 3%, not very significant. Of course, you see more nausea, vomiting with the chemo arm. Nausea was 13%, 17%. Anemia, more cytopenia, of course, with the chemo arm that you see with BTK inhibitor. Cardiac event, all cardiac event in the zanubrutinib arm was at 10% compared to the BR arm at 6%. And in the cohort with deletion 17, the high-risk group, the side effects were comparable to the other cohort. So it's a very well-tolerated agent, comparing it to chemotherapy. And also we see the PFS was very significantly higher, and that's why we are moving away from chemotherapy in this disease.
So obviously, the BTK inhibitors that we've been talking about have been one of the mainstays of frontline therapy. But the other drug class that obviously that we have to often decide upon is the BCL2 inhibitor, and we have one of those currently on the market, venetoclax, and it has been used in combination usually with CD20 antibodies. But more recently, I understand that trials are afoot to combine the two active classes of drugs, BTK inhibitors and BCL2 inhibitors, with or without a CD20 antibody. So one of these studies, the study shown here, the CLL13 study, is an effort in that direction. So what can you tell us about this study?
Yeah, so the important part of the combination of BCL2 and CD20 is the opportunity to have a time-limited approach of treatment compared to the continuous approach. And I like that approach, especially in younger patients, or just the idea of having a limited time approach compared to a pill that you're continuously going to take for a long time and potential side effect. So this trial looked at, had different arms. The first arm was first of all, included fit patient with CLL with good baseline kidney function, liver function, no prior therapy for CLL, and they excluded patient with TP53 or deletion 17. The trial included 920 patients, and the first arm included patient had combination of obinutuzumab, venetoclax, and ibrutinib. The treatment was for 12 cycles for venetoclax, 6 cycles for obinutuzumab, and the ibrutinib was continued for up to 36 cycles if the MRD was still detected. The other arm included venetoclax with obinutuzumab, and that was 12 cycle of treatment with venetoclax, but only 6 cycles of obinutuzumab. The other arm was venetoclax with Rituxan, and that included 12 cycles with Ven, 6 cycles with Rituxan. And the other arm is the chemo arm, which is 6 cycles of either FCR or BR. And they looked at the MRD negativity and other endpoint progression-free survival as well. So here we see the depth of MRD negativity, and we see in the combination arm with either ibrutinib, venetoclax, obinutuzumab, or venetoclax, obinutuzumab, very significant MRD negativity was seen, and that was like at 92% in the combination of 3 drugs arm, and 86% in the Ven-Oben arm. The Ven-R also showed 57%, and the chemo arm was at 52%.
And what do we know at this point about their durability?
So now we know that even in CLL, the significance of MRD negativity is important as for PFS as well. So the PFS at 3 years was very significantly higher in the ibrutinib venetoclax open arm, and comparing it to the chemo immunotherapy arm, also in VIN open arm. You see the curve with the VIN Rituxan is kind of slumping forward, but at least for the first 2 years, the progression-free survival was still very significant.
So you see a fair number of patients with chronic lymphocytic leukemia. So you do mention that if you have a young patient, often time-limited therapy is what you sometimes talk about in favor. So if you had 10 patients with CLL that you saw, how do they break down in your practice today between BCL2 inhibitor, BTK inhibitor, and then how do you, in the future or even already, decide upon combination of BTK and BCL2 inhibitor?
Yeah, that's a very good question. I usually like for continuous treatment with a BTK single agent versus combining BCL2 with obinutuzumab. I give the two options for the patient, their preference. Of course, the combination arm is more toxic at the beginning, more neutropenia, probably need for admission if they have high tumor burden. So it's more tough at the beginning, but the idea of it being time limited is, I think, very appealing for many patients, comparing it to the BTK single agent, which patient going to continue for hopefully for many years. So depending on patient preference, I do present the two options for the patient at this time. I have not used the combination of Obin-Ven, like BTK combining into Ven in the frontline setting. I've used it in the relapse setting, actually to gain more responses. But in the frontline setting, this has been my practice. I rarely combine the BTK inhibitor with the CD20 antibody. Usually I use as single agent. And again, it's very appealing in older patient with some comorbidities. It's a pill. You don't have to come very frequently to the clinic to get it. And most patients, especially with the second generation, they tolerate it very well with no major side effect.
So do you see any the depth of response being a selling point for BCL2, or you think that patients generally, as long as their disease is in control, don't really doesn't matter to them generally that you can tell them they're in a complete remission or not?
Of course, it's nice to see good numbers, and we know now it's connected to PFS as well. The deeper the response, the longer their progression-free survival. So it's, of course, it's an important endpoint, but again, I see it more important in a younger versus I see a lot of patients in their 80s and just a started patient is 90 on the
Sure.
BTK inhibitor. So for such a patient, I think it's important to have like a good depth of response. However, I think they still do well if they could take a pill and go home and enjoy their life as well.
Do you have a preference for high-risk patients like P53 to use a BTK versus a BCL2, or that doesn't anymore factor into your decision making?
So definitely no chemo.
Sure.
But we actually, there was a recent abstract in ASCO this year. It's not a randomized, but it was basically looking at a patient with like just retrospective data evaluation of patient who either received BCL2 versus BTK inhibitor in patient who were TP53 or 17p deletion. And it showed that time to next treatment was slightly better with the BCL2 inhibitor compared to the BTK inhibitor. So I don't know if that's a selling point. I think I still would use the age factor in there and the comorbidities and how much patient can tolerate and what they wish. But probably this data shot, maybe we can still use the BCL2 first as a time-limited approach in a younger patient compared to the BCL2, but I think more randomized data is needed.
So one of the things you mentioned with the BCL2 inhibitors, it's sometimes a little tedious about the TLS monitoring and the need for admission. And does combination with the BTK inhibitor make that early phase of treatment with the with BCL2 inhibitors a little less challenging?
That's true. Yeah, definitely. Like when reducing the tumor burden with the BTK inhibitor first before adding the BCL2 inhibitor, that's also a great approach and can avoid you that admission at the beginning. It's still like we need to look at the survival, and that's going to be like many, many years ahead.
Sure.
Looking at if you combine first versus if you sequence those treatment and use them at relapse, are we improving survival or not? That would be the main question.
So then I think another major advance in our treatment of lymphoid malignancies, including CLL, has been the advent of a new drug, pirtobrutinib. So what can you tell us about this drug and its utility in CLL?
Yeah, it's a great option that's now available for patient who had relapse BTK inhibitor and BCL2 inhibitor. As well, the PRUNE study looked at previously treated CLL patient. It was a multi-cohort phase 1/2 dose escalation expansion study, and included patient above 18 or above with the previously treated CLL. Good performance status, included above 300 patient, and has two main cohort, the BTK naive and prior BTK exposure, and looked at different endpoint, mainly the side effect as well as responses, and also safety and tolerability of this agent. And we know pirtobrutinib can overcome certain mutation that developed after other BTK inhibitor uses. So it's a very exciting drug, and we were very happy that's finally approved. The responses in this study showed that especially even in patients who were previously exposed to BTK inhibitor, responses were durable and like at 81%, which is very good. Of course, CR was not very high. Most of the responses were PR, but this is what we typically see with a BTK inhibitor.
And so what about the durability again?
Yeah, so durability was also, I think, it was good, of course, was better in the BTK naive cohort compared to the BCL2 exposed patient. With a median follow-up of 27 months, the PFS was 23, versus in the cohort with the prior BCL2 exposure, the median PFS was 15.9 months, and the 22.2 follow-up month of follow-up.
And to put it in perspective, is this something that you're excited about, this level of durability?
Definitely. I mean, now we are the era of seeing more of BTK, of patient who had exposure to both BTK and BCL2 inhibitor. So now we are seeing more and more of those patients, and like who relapse both agent, and it's good to have an option available for them. And of course, I'm also excited about the BTK degrader now in clinical trials. Of course, clinical trials is definitely the way to go. But BTK degraders will be another thing to look for in those patients. But definitely having pirtobrutinib available for those patients is a very, very good option.
So how is this drug tolerated?
It is relatively well tolerated. From the PRUNE study, we see that the all causes AEs were not very significant for grade 3 and more. Still, there was risk of fatigue, about 36% of patients, loose stool, neutropenia in the 30% range. Nausea was seen in about 22% of patients. Grade 3 or more infection risk was 30.9%. Of course, these patients were exposed to multiple agents as well. Of course, they were immune compromised because they're priorly exposed to BCL2 and BTK inhibitor. But again, the grade 3 event were not very high in like generally speaking. So it's still a well-tolerated agent. I do see a lot of arthralgia and joint pain, and the trial reported is 22%.
So with this drug, I believe that it may at some point even get approved for second-line use. So how would you sequence it? If you were using a BTK inhibitor in first line, would you go to a BCL2 inhibitor in second line before giving this drug? Or would you give this drug first and then give the BCL2 inhibitor subsequently?
Yeah, that's a very good question. It's hard to know without a clear data. I tried to space out the BTK inhibitor, hoping to gain some responses. So if patient had just relapsed on BTK inhibitor, I would give them the BCL2 inhibitor, and then at relapse, I would use this agent afterward.
And
just to hopefully gain some, some receptors back of some mutation back of the BTK, hopefully to get more responses.
And I believe that there's emerging data on the differing spectrum of mutations that emerge on the different BTK inhibitors and their potential sensitivity to the
Like what agent?
like drugs. Is that something that you've started factoring in, or is it too early at this time to know?
Yeah, I think it's too early. I don't send sensitivity or mutation analysis for now, but I think it will be good option for the future that we know exactly what the patient mutation like what the mutation they had and what the drug they might be susceptible to. But yeah, like my approach has been once they relapse on BTK, I use BCL2, and then when they relapse on that, I will use the pertubrutinib without mutation check, unfortunately.
And so another recent entrant into the treatment landscape for CLL has been a CAR T cell. So we've had Lysocell approved recently. Like, what can you tell us about this, and what is your opinion about its utility in CLL patients?
And again, like it's an important option. It's important to have the option available for patient. It's also like the main challenges went on this patient for the CAR T cell because you want him to have a good response, still good performance status before you send them out. But the Transcend CLL trial that led to the approval, it included patients who are relapsed, refractory CLL, SLL ineligible, or failed the BTK, and then failed more than 2 or more line of previous treatment, and they're at standard risk. And then the CR rate was in the group of 88 was 17 patient. That's take us to 19%. And the overall response was 48%. Median progression-free survival in months was 17.9, and the overall survival was at 43 months. So it's a good data, very good option available. And I think with Lysocell, the toxicity is very bearable. The CRS was also not very significant. Neurological event more than grade 3 was at 19%. So it wasn't it was very tolerable agent. Again, I struggle to see if patients are failing or progressing quickly, when to send them. I try to send them at response, like they're still responding, and I see some element of still just some elevation in their white cell count, or they stop progressing. I send them quickly, just because you need that time period before they progress so quickly, and you don't have other option to calm the disease down. But it's a very good option. We started using it at Michigan. I just sent a patient over for CAR T cell last week.
How do you choose between a patient who's double class refractory, giving them pirtobrutinib versus a CAR T?
Yeah, so I guess once they are double class refractory and they put them on the pirtobrutinib, if you don't see their responses, they're responding so quickly, or they're not in a depth of response, I start thinking of CAR T cell before they progress so quickly, because you need that disease to be under some kind of control before sending them to CAR T cell. So actually, the patient I sent had already had all 3 agents, and somehow he responded to Revlimid, which is, I didn't mention data here in the presentation. He finally responded to Revlimid, but I knew that this is his last resort of treatment. So I sent him to CAR T cell while he's actually in CR right now. It just so that you don't want him to be progressing, and then he'll have more side effect of the disease of the CAR T cell, probably less likely to respond as well.
So CLL is a disease of older, somewhat frailer patients. So I would assume that a select group of patients perhaps will be eligible for this modality of therapy. Is that fair to assume?
Yes, yeah. With Lysocell, the side effect is very manageable. So I think even for older patient, I would still think about it, especially if their disease is not, like their Y cell is not that high, and they are progressively slowly, not very quickly. I think I would still think about it, even an older patient. And to your point, somehow we are seeing more younger patients with CLL, but I haven't looked at SEER data if the age range had changed or not. But I've seen patients now in their 40s and 50, unfortunately, with CLL more and more.
We all have young patients as well. And
Mm.
it's good that our armamentarium of drugs is expanding. And you mentioned some of the drugs that will come down the road, BTK degraders, and perhaps even more BTK
Bispecific, we didn't talk
inhibitors.
about bispecific, but also probably coming as well. We'll see some more data for CLL as well.
So hopefully I can have you back to discuss some of these topics as they unfold in the future.
Definitely would love to be with you again. Thank you. Thank you for the invite.
I appreciate you being here. Thank you.
Thanks.